Hello, everyone. We've got an exciting session lined up for you straight after lunch. And what we're going to do in cloud computing and big data is we're going to take you on a journey, a patient's journey, coming into hospital, going into the intensive care, and then going home and how they're going to be monitored at home. And finally, we're going to end up with Jack from Google talking about some of the pitfalls and solutions of applying technology and machine learning to healthcare. So to kick things off, my name is Vishal Nangalia. I'm an anesthesiologist and an intensivist. And I encounter a problem almost every single day. I get referred patients who've fallen off that physiological cliff and need organ support, whether it's their hearts, their lungs. And every time I go and see these patients, I kind of go, why didn't you call me 3 hours earlier? Why didn't you call me yesterday? Or why didn't you do this when they first came in? And that got me thinking, how do we solve that particular problem? Looking into it more broadly, realized that happens quite often, and they're called adverse events. When the patient dies or gets admitted to ICU unexpectedly, it's a serious adverse event. And reports from the last 15 years in almost every Western country has said that almost half of them are because of poor care, and that could be not the right care at the right time, and half of these are preventable. So how do we solve this problem? I decided to use data. And because I'm slightly lazy, I thought I'm going to use existing data, things that I don't want people to do more work on and collect. In the UK, we don't have electronic health records in the majority of places, and all our vital signs are collected on paper. So I went, what's electronic, what's easy? And it turns out to be blood results. So looking at blood results, I was taught in medical school, you've got a normal range, so if your blood results, let's say sodium's between 135 and 145, you're good, and if it's outside, you're bad. So what does that translate to if you look at it in terms of outcomes? It means if it's between 135 and 145, you should do better than someone outside, so you should have a lower risk of dying in hospital or any other bad outcome. In reality, that's not true. You see that it's continuous. And that continuous nature, these are all normal results. You've got someone who's got a 1% mortality if it's 140, and a 3.5% mortality if it's 135. 250% increase, and this is all counted as normal. So we've got a baseline in medicine that is built not on evidence, but is technically wrong. So what did I do? I collected more data. I went around the UK, my country, from NHS hospitals, 20 of them, and collected about 500 million blood results on 8 million patient admissions over the last 10 years. Did a lot of number crunching, built algorithms, and because I'm a clinician, I wanted to bake it into the workflow of what clinicians normally do. So we already use algorithms in medicine. We use them in multiple places. And we're bringing in new algorithms every few years that are driving clinical guidelines in healthcare. And one of these is acute kidney injury. Acute kidney injury is a very big thing. The renal physicians over the last 10 to 15 years have redefined renal failure, acute renal failure, to a syndrome of conditions called acute kidney injury. And you diagnose this by saying, if your creatinine, which is one variable in your blood, goes up by 50% from what it normally is, you have acute kidney injury. But if it goes up by 100%, that's really, really bad, and that's acute kidney injury stage 2. So you're much more likely to have a bad outcome. And the worst way is if it goes up by almost 3 times your baseline, and that's acute kidney injury 3. So these are bad things, and in the UK, a program of work was done which said that you need to identify every single patient who has this, so implement this algorithm, and direct care towards them, and 0.5% of the hospital budget, not for these patients, but the total hospital budget is going to be based on you implementing this correctly. So a lot of money is involved here. So the performance of these systems, and this is based on the data set I've just shown you, is acute kidney injury 2, if 100 people have acute kidney injury, and die, well, 100 people die or get dialyzed from acute kidney injury, they're their standard outcomes in hospital. If you've got the second worst form, 1 in 4 people who are diagnosed with this will die or get dialyzed in hospital. But only 15%, so 15 out of those 100 people who die, actually get that acute kidney injury too. Acute kidney injury 3, which is the bad bit of it, the really bad bit of it, is 1 in 3, so only 33%. But again, only 16 out of those 100 people die or get dialyzed, who die or get dialyzed identified by this algorithm. Is there a better way? Remember, this is the gold standard that's currently implemented in the UK, and it's recommended across the world, including the US. So doing some number crunching and using prior data only. So nothing new, it's blood results that are associated with this and administrative data. My machine learning algorithm basically, at the same level of AKI3, identified 95 out of the 100 people who are dying from acute kidney injury. Implementing this is kind of easy because you're not kind of telling the clinician it's a new workflow, do something different. We're just slotting out one algorithm and replacing it with another one. And here, you're identifying more patients quickly, and you don't have to see too many. So it reduces their workload, kind of going along with my lazy philosophy. But not everyone cares about acute kidney injury. What they also care about is people dying in hospital. And these are 2 other kind of examples of people dying in hospital. And the algorithms that I came up with, the existing one says we can capture 20% with a 20% likelihood of them dying. And the algorithms we've come up with show with the same probability of dying, we can capture 75 and 88%. But just producing the algorithm doesn't help. We need to implement it. And we don't have electronic health records, so we built a system that works off messaging and can be implemented in any hospital around the world. We linked it up to 4. And rather than just saying this patient has an alert, we called it actionable insight, where if you get referred a patient who's going to die, you want to know some extra information. So we tell you where the patient is, what they're doing, what their comorbidities are, and what you should do next. And I think that's pretty cool. But unfortunately, the clinical world's not ready for this yet, or it hasn't been deployed yet. So there's still a long way to go. But moving on from the general ward in hospital, Kurt's going to talk to us now about the intensive care.
Well, thank you very much. I feel very grateful to be up here on stage. I guess I need a clicker to move myself from one slide to the next. I am going to start off by, go back. That's nasty. All right. I've already spilled the beans, guys. All right. So I'm going to introduce myself in photographic metaphor, and we're going to start in the bottom left corner of the screen. That kid's about 20 years younger than I am, but man, I like his style. That guy's doing business while he's doing business. If I ever meet this guy, I'm going to hire him, or he'll hire me one way or the other. I want to work with that kid. The top left picture there is kind of my ideal self right now. I would love to go out and enjoy the majesty of nature and then plop down for lunch or take a break, pull out the computer, crank out a couple of algorithms, save a couple of thousand lives, and call it a day. And then I heard I was going to get to come to AI Med and give a talk. And I thought, oh man, this is awesome. I can be anything. I'm going to be a cloud. So I had this great vision. And then I get up on stage and realize that reality is a little bit more like this. All right. So I am honored to be on the stage with all of these awesome people. But I am probably not the most awesome one up here, but I'm happy all the same. All right, so I'm a pediatric intensive care doc. I take care of sick kids that are really, really sick. They're on ventilators in the hospital. We give them medicines that help their hearts perform to the level that it needs to perform so that they can keep their bodies supplied with oxygen. And despite the fact that we've got all of these nurses and doctors watching after these kids, 20,000 times a year in the US alone, they have a cardiac arrest in the ICU. If you have a cardiac arrest in the ICU, half the time you're gonna die. All right, and if you don't die, most of the kids that survive it have some kind of morbidity associated with it, so it's kind of a big deal problem. as a clinician, when I go back and look at an arrest, more often than not, I can say, yep, about right here, I can see that that arrest was coming because the heart rate started to go up, the blood pressure started to go down, and the pulse pressure started to narrow a little bit. So, you know, having that retrospective data and the ability to go back and analyze after the event, sure, that's very powerful. It's easy to go back and, you know, play Monday morning quarterback and say, well, why didn't you see that? But the fact of the matter is we don't see it all the time. So the work that I did when I was getting my informatics training was basically taking this concept of I'll look at the history of data leading up to the point and using that as my mental model of predicting an arrest. In the red down there, that's traditional models. You take a snapshot at one point in time and say, is this kid going to arrest or not? That does not predict arrest very well. You have to have that time series phenomenon in there. And that's what the blue, green, and yellow are all about, is kind of these different types of data that can be incorporated into models. And those graphs on the right basically just show that that technique works to improve the performance of the prediction algorithms. So that in and of itself was not that big of a data. I had minute-by-minute measurements, which was a big pain in the butt for me to process. But we're moving into a world where, well, where's the next signal going to come from? And to me, I think the next big set of signals is going to come out of the morphology of the EKG. So these green lines here on the left are one patient before they have a cardiac arrest. And it doesn't take a data scientist to realize that those are different from one case to the next. Now, right now they're just squiggles on paper, but there's about 100 different ways that you can encode these and make, you know, basically mathematical representations of them. And I've got a fellow, Tom Fogarty, who's here with me this week, that's going to be presenting some of this later tonight. And then you can make pretty pictures out of this to kind of see the whole thing all at once. That's actually a 3D mesh model that you can rotate and kind of see what it looks like over that hour leading up to the arrest. I want to put a little caution out there and say that, you know, we're here talking about big data, and most people, when they're talking about big data, they want to talk about everything. You know, I've got a genome that's got so many exabytes of data. I've got an exome. I've got a microbiome. You know, a dog can come by my bed and sniff and say, well, you know, if he wags his tail up, it's going to be an arrest, and if not, down. I would argue that as you start off on a project like this, you don't need to be thinking big data. You need to go fishing where the fish are. So in the ICU, most of that money is in telemetry. That's where we started. That doesn't mean that there's not going to be some more signal in some of these other technologies, but you've got to limit your scope a little bit. And talking about limiting scope, another thing that is really, I'm still struggling with this, is let's say I build a great model. Well, that model is going to be based on some kind of operational set of parameters. You know, for me, I chose that in order for you to qualify for my arrest cohort, we had to do 2 minutes of external cardiac massage on you to say that you were a real arrest. Because there's some kids that have an unplanned extubation, they get a couple of thumps just for, you know, show, and then they recover. But those kids didn't have shock going into their arrest, so we excluded them. But if we influence behavior and people start to change the way that they treat kids, the nature of that arrest is going to change, so we're going to have to update our model. So you're going to have to get closer and closer to the point in time where you're going to make the initial intervention, and eventually our targets may not be the arrest at all, but the interventions that precede them, and which of those are necessary versus unnecessary. Sticking with my metaphor example, I'd say that big data is a baby, okay? Now, nobody's interested in a baby. Babies are kind of boring. They don't do anything. When you have a baby, what you're really wanting to have is the next president of the United States, or a quarterback that's going to win the Super Bowl, or you've got some big vision about what your baby's going to grow into. But in order for that baby to get from point A to point B, you're going to have to love it and nourish it and realize that there's going to be points in time where it frustrates you big time. Okay, and this baby knows that it's going to frustrate you, and it's already flipping you the bird because it knows early on what is in store. So the recipe for success, at least as far as I can tell at this point in time, is in order to raise this baby, you're going to have the right environment. From the top up, the CEO of the hospital, all the way down, you need to have the right culture in the organization, and you need to have the right vision that this is something that we're going to engage in. This is not a one-man show. You need a good leader that's going to know where you're going to take this baby, you know, which direction and advice you're going to give it along the way, and you need to protect it from all the external influences that are going to try to kill your baby along the way. Resources, you're going to need a team of people that have different skill sets. You're going to need people that know how to work with data, people that know how to work with patients, people that know how to work with administrators. And all of these people are going to have to work together to make this thing happen. And you've got to protect them, because I can tell you right now, all the people that know how to work with data in our institution, when it comes time for U.S. News and World Report to happen, whoop, nobody else gets any service until that's done, and that's a 6-month phenomenon. So you need to protect these people, and I'm out of time. All right, close enough. Y'all get the rest of it. Thank you very much. Okay, you did that.
Okay, I'm going to be talking about dumbing it down a little more from these brilliant guys and really talking about some real practical stuff around readmission. So the problem is that 30-day readmission or mortality out of hospital is really a bad outcome. Would we all agree with that? So we want to be able to do things. And where I was previously a CMIO, we created clinical dashboards to really monitor all the clinical outcomes. And we found that we could influence physicians by giving their data near real time, both at the health system level, at the hospital level, and down to the provider level. But we could never get our arms around the concept of post-hospital mortality and readmission, because that often happened outside the border of the health system. And so we have a difficulty inherently tracking this, because the data may occur somewhere else. Now, this may not be a problem among pediatric hospitals, but certainly among acute care, where there are penalties by Medicare patients. And these penalties last year, as of October 1, were $528 million and affected almost 100%, or 50% of the 5,500 hospitals in the United States. So, and they track them against 6 conditions: CHF, AMI, pneumonia, COPD, total joint replacement, and CABG. So that's what we're talking about. And there's inherent gaps in how we actually look at the data, and we were never able to solve this because the Medicare data is given to us 3 years after the fact, along with a warning that you've gotten a penalty. So it's hard to do good performance improvement when you're talking about 3-year-old data, because it's not very compelling. So if you look at your enterprise data warehouse, you only have the data that occurs within the walls of your health system. On the HIE side, you get a little more data, but you don't have data from all the primary care doctors that are following up on these patients once they leave the hospital, because a lot of the primary care doctors are still not in HIE land. You ACOs are a little bit better than the HIE data, but it typically comes about 6 to 9 months after the fact. So it's a little late to make determinations on it. And then there's this concept of community ADT feeds, where people participate on submitting their ADT data to a central clearinghouse or a kind of social network, if you will, and there's been products committed around this. But again, it requires somebody to do something, and it's only good for the subscriber base. And finally, the reason we do all of this is so that we can get better predictive analytics and not just a crystal ball, so that we need real data to do this. So what we're doing is taking a patient query and following a patient at 30, 60, 90 days after they've been discharged from the hospital, and this is Medicare patients. We're doing the query from the charge data using a very proprietary system through the Medicare patient portal, which is called the Blue Button, and doing eligibility queries where we can actually tell if the patient died, and if so, when they died and where they died, pulling this all together and actually following the patient, not following the health system. And we're able to do this. This is considered really a throwaway solution to feed more data into the predictive analytics. So I'm kind of the pre-big data in what we're doing here. And we get very robust data, as you can see from the data sets that actually come from this. It's done very inexpensively because it's completely automated, and it allows the hospitals to do performance improvement projects on real data to really determine within their health system what should they be doing different. And often it's primary care follow-up needs to be quicker to the hospitalization for certain diagnoses. It may be remote patient monitoring, connecting patients to devices. But I'm finding that the predictive analytics, although these models are pretty good, they're not as compelling to the practitioners as their own data and following even down to the provider level who is problematic in their readmission data. So you can also do clinical decision support around vaccine stewardship, because in these data feeds from Medicare, you actually see all their vaccination history because Medicare pays for that. And I think there's a huge amount in today's vaccine shortages in getting patients to not have 2 and 3 flu shots in the same season or pneumovaxes, because the knee jerk is when they come into the hospital, we revaccinate because nobody knows if they got it or not. So this is currently going into pilot, and we hope to do a lot of predictive analytics on it.
So, there we go. So I want to talk briefly about some of the work that we've done in healthcare and then some of the challenges that I think Jeremy and other folks have talked about this morning, and talked about some of the ways that the machine learning community, the deep learning community, have already started to tackle some of those issues. So this is a paper that was mentioned a few times during this conference. It came out on JAMA a few weeks ago, talking about the essentially using deep learning to look at diabetic retinopathy. So as you can see, we have very good results on sensitivity and specificity compared to looking at an average of ophthalmologists. There is a few interesting results that you can see here, which is if you look at the upper right-hand side, we generated a lot of labels. So we generated almost 500,000 labels. You can imagine most institutions do not go through this process of generating 500,000 labels. I mentioned in a previous talk that really deep learning works very well when you have a lot of label data. If you don't have a lot of label data, it doesn't work nearly as well. So this is obviously an issue that many have in medicine. We also trained on a lot of images. And that itself is also very difficult to gather. So I think this has already come up a few times, and I want to talk about some of the ways that folks in deep learning have already started to tackle these 3 issues. So one is, I think May mentioned this earlier, deep learning right now is frequently treated as a black box. So you saw a number of predictions around the bone age or things like diabetic retinopathy, or whether a patient is going to deteriorate. Right now it's just treated as, you know, this person will deteriorate or this person will not, or this is the age. You don't really know why that's the case. Another thing that was mentioned was that right now a lot of these data sets are very sparse. And the last thing that was mentioned, and I think you guys saw, was that you need a lot of labeled data. So if every single deep learning thing requires us to go get medical students and fellows to label 500,000 images, we're going to be in a lot of trouble very soon. So first, looking at some of the research that has been recently done, this is actually not from us, this is from a number of folks in Canada. The community have already started to develop ways to parse apart what is actually happening in the deep learning models. So in this case, I mentioned Google has done some work on looking at the image captions of pictures. So this is looking at the prediction of the image caption and looking at what the model is focusing on that particular picture. So you can see, for example, this sentence, a person is standing on a beach with a surfboard. You can see that as they talk about a person, use the sort of the lighter white is where the computer is actually focusing its attention. These are sometimes referred to as attention models in deep learning. And you can see sort of beach and other things here. But one of the things that this really helps with is, of course, when it's wrong, you actually can see and start to debug, I think this was mentioned earlier, where some of the issues happen. So for example, in this case, it mentioned a large white bird standing in a forest, and you can see that basically the model seems to think that the giraffe is a bird. Or in this case, that the picture on the sweater is the clock. So this allows folks to start looking at the results and looking at the training to see what went wrong. There is now work also done on text. When you start doing NLP analysis, a lot of folks here I know are interested in looking at notes. We're able to start looking at questions that get asked. So in this case, after the computer reads this paragraph, you ask the computer, you know, what was the entity that actually, who was the deceased sailor? And you can see in this case the different potential things that the computer looked at, and the red was ultimately what the computer picked. So it's this attention model type work and this came out of DeepMind a few years ago, I think 2 years ago, we started to look at technology that allows us to figure out what is going wrong. So another thing that is very difficult to deal with is that in many, many applications, in particular in the ICU cases, we would love to train over a lot of data, but of course, as clinicians, we also don't want a lot of patients actually in ICUs. So that means we're dealing with very few examples sometimes of things we really want to detect. So some of the things that have happened is this concept of transfer learning that I think Jeremy also talked about earlier. So the diabetic retinopathy model was actually bootstrapped using a lot of images. It was using Inception version 3, which was the ImageNet type models that we built earlier, and we used that to help pre-train the model. So in this case, we're looking at Google internal, looking at translations. So we have a lot of data on English. We have a lot of engineers who knows English. But we also build a lot of translation products in other languages. So in this case, we're looking at Portuguese. We have many fewer data, and you can see that the word error rate is much, much higher. So one of the things that we found is if we were to use the weights of the deep learning model from the English model and use it as the initializer for the Portuguese model, we start to bring down the error rates. And we're able to do quite a bit of improvements on some of the error rates. This is a few years old, but we're able to now do quite a bit of decrease in these error rates. And the last thing I want to talk about is labeling, right? So we did a lot of labeling on diabetic retinopathy. It's kind of painful to do. So is there a way you can start to do unstructured learning? So if the stuff isn't labeled, can you still learn interesting things from it? So we looked at YouTube. We basically looked at a lot of videos from YouTube and tried to figure out maybe we can get deep learning models to spit out interesting things without actually telling it what the actual labels are. And you do that by having the deep learning model learn its own images, but try to have fewer nodes in the middle. And one of the things that we've noticed is if you were to then back out some of the nodes, you can basically look at what images or what mathematical functions really trigger the nodes. We can actually back out interesting things that the computer learned that we didn't tell it to. So in this case, the computer actually figured out that a face typically looks like this when we didn't label anything as faces. And of course, since this is YouTube, we have a lot of cats. And the deep learning model also actually picked up that there is some morphological identity that looks like a cat. And that also got picked up in the model. And this is completely unstructured. To be clear, this is a little bit early. So the ImageNet accuracy right now is up to 98, 99% for labeled images. And this is still in the 15, 16% accuracy. If you were to randomly guess, the error rate would be, the accuracy rate would be in the 0.006% rate. So this is still pretty good, but this is pretty early work that's being happened right now. Cool.
Thanks very much, guys. So to kick off the questions, I'm a bit of a sci-fi buff, and William Gibson, who coined the term cyberspace, I think said over about 15 years ago, the future is already here, it's just not evenly distributed. And each of you are doing great work in your own individual institutions or individual companies. How do we distribute or get clinical buy-in to actually use it and not just make it research or a pilot phase? Anyone?
Well, from my standpoint, I like to get the data back to the actual practitioners so that they can actually see their own outcomes and be able to follow it. So it makes it really real. So I call it actionable data because if I can't change behavior of clinicians, I'm not going to be really effective. And we were able to do that in a large health system on a lot of metrics, but we weren't able to really influence mortality and post-hospital readmission because there wasn't really any data to give any feedback. So people start throwing lots of solutions on the wall, not knowing what they should really be focusing on by the physician. Because if we try to throw one solution for everybody's situation, we tend to look silly because we inherently, as doctors, say, well, that data doesn't. My patients are sicker, or it doesn't fit me, so we tend to ignore it. So by getting real data back to the practitioners, that's one way to influence behavior.
So I am obviously very fond of physicians and clinicians in general, but one of the things that we've started to do at Google is to engage patients directly. Frankly, one of the reasons is we know consumers very well and we don't know the clinicians as well. So if you use Google search, you can actually see some of the machine learning in healthcare already applied. You can search things like symptoms on Google search, and there are actually significant machine learning going on in the background to output results. So we really like to get patients more engaged in their own care, but frankly, this is a big movement that has to involve a ton more folks than us, Apple, and even just the providers. There has to be a lot more engagement across the community.
I don't know that I'm going to answer your question directly, but I think that, part of this, we've talked about where does the data live right now, and all of the things that we're talking about need data. And I'll say, at least my experience with it is hospitals don't really want to give it up because there's no ROI, there's risk of what happens if IDs get compromised and it ends up being re-identified and coming back to them. So there's a lot of those barriers, but I still think that if you could somehow just get this stuff out there and have a big, huge lake of data that is healthcare data, and then let the masses, let everybody in the world have access to it, you're going to have a lot of people that piddle in it and don't do anything meaningful, but you'll have that 1 in a million kid that comes through, 17 years old out of the garage, that invents something phenomenal and changes the paradigm of the way we see that problem. And if you engage either hospitals or providers, healthcare providers, or even the community to say what are the most important problems you want solved, and you attach monetary values to that, you're going to increase the number of people competing for that particular prize, so to speak. So that may be a little bit of an obtuse answer to your question, but there it is.
No, that's great. Well, that kind of leads into the one question that's just up there, and I'm not sure if Poe can answer it, but what is Google's model to commercialize clinical analytics?
So I'll answer, I feel like there are a few questions I'll answer. So one is on the diabetic retinopathy thing. What we mean by labeling is we have a number of ophthalmologists who look at the picture and say whether this is mild, this is severe, or whether there's no disease looking at the picture. So literally finding out the ground truth. And you guys are absolutely right that sometimes it's unclear what the ground truth is. And we basically do that by over-reading the image. So we have a lot of ophthalmologists read every image and look at essentially the majority or the consensus. For the question about what is our model to commercialize clinical analytics, we are not honestly thinking about that right now. You can see that we're in pretty early stages and we're publishing in clinical journals. We are much more interested right now in figuring out if deep learning can really make an impact from a technological point of view. Does this technology work or not? We have some indication that it works very well in imaging and audio. We're interested in seeing whether it really works and discover new insights on things like EHR. We'll worry about the commercial entities later. Translate, for example, is something that we found that works really well, and frankly, I'm not sure we commercialize it at all, but it's been very helpful to all the users that we have.
That's great. So I guess following in from that, considering rehospitalizations questions, no, I meant the one below, closing the loop. Does anyone have an example where machine learning or AI has been used and has produced positive clinical outcomes?
I can't comment on the AI piece of it, but I know that about 10 years ago, we started creating actionable alerts within the EMR so that we could influence performance, the process measures of National Hospital Quality Measures. And we began following that, and we actually commercialized it and deployed it within Cerner's EMR to create closed loops so that we could actually improve performance by giving real-time actionable alerts to the clinicians, both nurses and doctors. And the thing we found is, number one, you have to give the actionable alert to the person who can solve it. So don't give a doctor alert to a nurse, and don't give a nurse alert to a doctor. And recognize the fact that the measures are always built for a non-clinical environment. They're meant for a retroactive. So we had to work with Medicare and Joint Commission to get them to change some of their measures. And I think on the AI side, we were able to actually create from this data a model to start working with the Global Trigger Tool, which is the IHI model of looking at potential harm in the hospital. And by reducing that, we were able to reduce $192 million in cost to the health system. So and that was published in a peer-reviewed journal. So I think that you can get there, and you don't always need artificial intelligence, but you do need big data and good systems to deliver that to the clinicians so that they will own it and make action on it while it still has the ability to influence the care of the patient in front of you and not what happened 6 months ago.
So talking on big data, what do you think the challenges are, apart from, I guess, HIPAA or ethics, on creating? I mean, we've got a lot of people in the audience, everyone, or most of us who have done great things. How can we collaborate? How can we create a common big data repository that anyone can access? I mean, Mimic's amazing, but it's still one site, and I know they're doing work on bringing other countries in, but how do we create it for pediatric intensive care or diabetic retinopathy or discharge planning? Does anyone have any ideas?
You just start. I mean, I don't have an answer to this solution, but having been talking about this same problem for about 5 or 6 years now, actively, it seems like most of those conversations get stalled at some kind of an administrative level and kind of what are the rules around how this is going to operate. And as time goes on, I'm simplifying the scope of this, thinking if you can just get one thing in there and start with that, then that provides the nugget from which everything else can start to grow and add on to. So rather than talking about integrating all these big systems en masse, start with one small piece that people can agree on that is relatively low risk, do it, and then add another little bit higher risk, and you just kind of let it grow over time organically.
What would be that one small piece you start with?
Hell, I don't know. Creatinine. You're the one that wanted to do the acute kidney injury. Let's get everybody creatinine together. You know, there's going to be inter-hospital variability, right? And you know, or you're going to have to somehow normalize the population at large. You're going to have to start to risk adjust it, but just get the creatinines together. And then people can kind of see what that looks like across the country, how it compares to the US or the rest of the world. And then you throw in some BUNs, and there's the next step, and say, well, how do those relate? Are the ratios the same? Or it sounds small and dinky and non-productive, but it's a way to start. And I think the problem is you just got to start somewhere. And until you get consensus on what to build, you know, nobody's going to agree on some comprehensive model. That's my opinion.
I agree with some of the folks who've been writing in that one of the big issues right now in healthcare, and something that the computer science community has tackled for a while, was the creation of common data sets. So right now, Mimic data set is an amazing data set, but we keep asking folks to come and innovate in healthcare. But frankly, they have no idea what any of the data looks like. We've done hackathons as part of the government, where we ask people to reimagine what the EHR looks like. And you get a lot of entries that are frankly changing what the colors and the buttons look like on the EHR, because those folks, the folks who are eager to help, have absolutely no idea what data is in it and what the workflows are like. So I think that's a big problem in terms of innovation. It's also a big problem in terms of research. We have a lot of papers coming out that nobody can replicate because, frankly, we don't have each other's data sets. And that's going to continue to hound us until we do something about it as a community.
I'm impressed, though, with things like Patient Like Me, where we have people voluntarily submitting their data every day. And I think that's a model that gets by the HIPAA requirements, because the empowered patient will want to submit their data. And then in oncology, we see this great collaboration between the James at Ohio State and Moffitt Cancer Center in Tampa and some other ones, the Orion Network, where they're all submitting their oncology data to one database and allowing data scientists to start looking at it. So I think I'm a little more optimistic that it's starting to happen already. It will never happen fast enough for us, but there are some great inroads being done. But I think ultimately we have to reach out to the population as a whole. And I think as patients feel more comfortable submitting their data to sources, I think that's going to be a big breakthrough of data that we can begin to look at.
And I think we've run out of time, but just on that last point, there are national level data sets available. The NHS has a CPRD data set which has effectively about 16% of all general practice records, including every person's blood results. Scotland and Wales have an integrated electronic system where everyone's blood results and claims, their equivalent of claims data, goes into one repository, and it's accessible from anyone in the world for research purposes. And I know Taiwan's got it, Sweden's got it as well. But on that point, thank you very much to all my co-presenters.